I think we'll have a very less crowd. I'm very thankful to AIOS and all my speakers, and we are the only one who are going to have a discussion, and I'm sorry I have to leave also because I have a flight. So I'll be discussing the challenges in diabetic vitrectomy. This is the first talk. How to control the bleeding. I don't have any financial disclosures. So diabetic vitrectomy is like a war. We have to control the bleeding and prevent the formation of retinal breaks. I always instruct that if there is a hemorrhage, it's better to stop, control the bleeding, so that visibility is not a problem, and then proceed with the surgery. So with the advancing technologies, better viewing systems, I think the success rate has greatly improved, but still I think diabetic vitrectomy is still a major challenge, and we always, if I have a diabetic case, I am always prepared beforehand. So this is a simple diabetic TRD case in which you can just do most of the dissection now with the help of these 25 gauge cutters. Scissors is rarely needed. So most of the removal of these bridging tractions can be done with the help of a cutter. You can go very close to the retina, do most of your dissection, just trim them, and if there are any bleeders, you can just diathermize the cautery, use a cautery or even endo laser to stop the bleeding. And if there are no breaks created in such a case and the retina is flat or there is a mild traction, there is no need to put a tamponading agent also. So in this case, just after doing the vitrectomy, PRP was done. So however, as I said, if there is a mild bleeding, you can just cauterize it. A bimanual approach in diabetic vitrectomies is very helpful. You've got two hands, you can aspirate with one, you can do a diathermy with other, you can do even laser with the other, you can coagulate these blood vessels. I always recommend to do vitrectomy outside in rather than starting at the optic disc, because if there is a hemorrhage at the optic disc, a massive hemorrhage, then sometimes the surgery becomes very difficult to proceed. Still, if the bleeding is not controlled, you can either manually press the bleeder with the help of the cutter or a soft tip, or you can just now raise the IOP by just pressing a button with a foot switch. Now it has become very easy, but you have to be very careful that the optic disc is usually compromised in such patients, and you can hamper the bleeding. So the IOP should, you can hamper the perfusion of the optic disc. So it's very important to lower the IOP, recheck the bleeders, and monitor the time the IOP is raised. So this is another video just showing the outside in approach. So I always prefer to clear the vitreous from the periphery, and then once that is done, this is the central tractional band which is present at the optic disc, which is causing a localized TRD. So just, and then you can gently release these bleeders. So generally with this approach, you can avoid a massive bleeding, and the majority of the peripheral work has been done. So again, after just doing the cutting the vitrectomy, I am not using any scissors. Most of the dissection now I do with the help of a cutter only. And after releasing all these tractions, if you're lucky enough not to have created any break in a detached retina, then you can go ahead without any intraocular gas or silicone oil. I usually avoid in diabetic cases. So again, once all the dissection, this is released, you can coagulate these bleeders. Endo laser is also very good. Sometimes in diabetic cases, I prefer to do a foveal sparing ILM peeling also, as in this case, and followed by a panretinal photocoagulation. However, still if there is a persistent bleeder, it's always better to plug all the plots and better to use valve cannulas, wait for some time. In most of the cases, the hemorrhage will stop. However, still if there is a persistent bleeding, then I'm very fond of using these heavy liquids, PFCL. If there is no break in a tractional retina, you can use PFCL. But if there is a break in the tractional TRD, in the area of the TRD, the PFCL can go subretinal. So it's always better to use PFCL if there is no break. So PFCL, it pressure tamponades the bleeder, and then you can remove the membranes under PFCL. So this was a case in which there was a persistent bleeding which was coming from the optic disc, and after injecting PFCL, then I remove this membrane with the help of a forceps. You have to be very careful because it can lead to formation of breaks. So very gently and a tangential traction. So if a clot is formed at the disc and it's not very large, you should not try to remove it. It will lead to rebleeding, which can be much more worse. You can do an endo laser under PFCL. It pressure tamponades the retina against the RP, and we get a good laser reaction, and then you can proceed with your case. So this is another video in which I just wanted to highlight that I've done everything. There is a hemorrhage which is present underneath the PFCL bubble. I will remove this clot, but at the end of the surgery, there was again the formation of the clot. So sometimes it's better that if you have a small clot which is formed at the optic disc and the retina is well attached, you should not try you should not try to be very heroic and remove all the clots, because the secondary bleed can be more problematic. So although I removed this bleed under PFCL, so in the end of the surgery, when I did an air fluid exchange, there was some amount of bleeding which again came, so it was not very fruitful. Rather, I could just have aspirated the active blood which was there and left the clot. So this is at the end of the surgery. So this is another video in which again I'm just highlighting the use of PFCL. There was a tabletop tractional detachment. The peripheral retina is attached. It's a very old RD. So under PFCL, I removed this membrane which was very tightly adherent to the retina. So you have to be again careful. There are very high chances of creating a break. Lucky for me and the patient in this case, I didn't have a break. So, and if you don't have a break, you can just leave the tractional detachment. I did a peripheral laser in the attached retina. So this membrane is being removed under PFCL, and I left the TRD which will settle over a period of months, take months to settle. But if you're sure, then there is no need to put silicone oil if you have not created a break, if you're very sure. So this is the laser which has been done in the peripheral attached retina. You can see that there is a tractional detachment which is present in the center, but I've relieved all the traction, and I'll just leave air inside the eye. So this is another video in which I'm using PFCL as a tamponade by tilting the eye, a small bubble. I did the peripheral vitrectomy. There is this center fibrovascular frond which is very tightly adhered to the central macular area. So there is a continuous bleeding. I have inserted a PFCL bubble. I'm just tilting the eye and continuing with the dissection. This is a case in which I used the scissors because the plane between the retina and the fibrous vascular proliferation was very close, so I had to be very safe, and this was a one-eyed patient. So under PFCL, some of the dissection was done, tilting the eye and doing other dissection. So I didn't want to be very aggressive in this patient, removing all the bands, because this was a one-eyed patient. So just relieving the traction and the maximum which I could give this patient. I just go to the, so as I said, so PFCL can be used as a very effective agent for tamponading bleeders if they are not controlled. So this is the fundus picture at 1 week, and then at 1 month I just left this frond because this was a one-eyed patient. The patient gained a vision of 6/12 after 1 month. So if the bleeder is not localized and there is a continuous bleeding, it's always better to stop the surgery. You can give an anti-VEGF, but you should not do a blind surgery and create a break. Probably operate after some time if really it is so bad. And there is another option which I've used in few cases. I left PFCL inside the eye, like in a GRT, in which I've done quite a few, and then you can re-operate after about 3 to 5 days, remove the PFCL, proceed with your surgery, and you can use a intraocular gas or oilless tamponade. So this is again a use of PFCL. If you have found a proper plane, you can use PFCL to do the dissection. You just inject PFCL in the plane between the retina and the fibrous tissue. This can be used in cases in which the vitreous is not very tightly adherent. You've got broad-based adhesions, but you've got focal adhesions. So just inject PFCL in between the plane. It not only prevents bleeding, it also creates a separation between the retina and the overlying vitreous fronds, and then you can gently proceed with your traction, and I think that will also protect the underneath retina. So gradually in both the videos, the dissection is being done from the center to the periphery. I normally said from the periphery to the center, but in this case, since most of the adherence was present at the region of the optic disc, so I had to proceed from center out. So this is another approach which you can use. You can inject PFCL if there are not broad-based adhesions. So I'll just go forward. So again, prevention is best. You should have a good control of the hypertension, anemia, diabetes. Antiplatelet use in these cases should be suspended, maybe not in all VRs. If the patient is on anticoagulants, it's always better to do a INR and prevent excessive bleeding. So although they do not affect the final outcome, but they prevent bleeding intraoperatively and postoperatively. So a good systemic control is very good to prevent complications. So anti-VEGF, I think they have really revolutionized the management. Given 3 to 5 days before, I prefer to give it 3 days. They greatly reduce the incidence of bleeding, and they have made the surgery quite easy. So putting it all together, I think everybody has their own techniques. The ones which I highlighted, that it's better to use valve cannulas. You can use a bimanual technique, which is really helpful since you've got both your hands free. You can aspirate with one and coagulate with the other. It's always better to cut the hyaloid from the outside in approach. And the use of use of anti-VEGF agents, I've already said, you give it 3 days before. It really helps in controlling the bleeding. You should not try to pull a fibrovascular proliferation at the disc. It can lead to a very severe bleeding, which is difficult to control. And the use of PFCL, I've already highlighted. It really pressure tamponades the blades, gives a clear media. You can do laser under PFCL, and in very, very extreme bad cases, you can even leave PFCL inside the eye. But very important not to create a break in the tractional area. So thank you all.